Vomiting. Key points. Bilious, dark green, vomiting is due to a gastrointestinal obstruction until proven otherwise, and requires urgent surgical referral. In a vomiting child without diarrhea, consider causes other than gastroenteritis. Intracranial causes, e.g. non-accidental injury, NI, should always be considered. Ondansetron can be used for symptomatic relief, however cessation of vomiting does not exclude a serious cause. Background. Vomiting is a common and nonspecific symptom, not a diagnosis. Infection is the most common cause of acute vomiting. Bilious vomiting occurs when there is a gastrointestinal obstruction. Bile is dark green rather than yellow. Using a visual aid to clarify vomitous color with families is helpful. Early morning vomiting and headache may be due to raised intracranial pressure. Differential diagnoses by age. Assessment. History. Symptoms and signs associated with possible diagnoses. Table below is not an exhaustive list and presentations can overlap. Nature of vomiting. Differential diagnoses. Bilious. GIT obstruction. Blood. Swallowed blood, e.g. epistaxis, or in neonate from maternal blood due to delivery or nipple. Trauma. Upper GI hemorrhage. Projectile. Blank. Early morning vomiting. Raised ICP. Associated signs and symptoms. Evidence of diarrhea. Blank. Fever or systemic illness. Blank. Bowel sounds. Abdominal distension and tenderness, tinkling/absence of bowel sounds. GIT obstruction. Blank. Migraine. Intracranial pathology, i.e. raised ICP. Infection. Rectal bleeding. Blank. Blank. Meckel's diverticulum. Colitis. Other. Previous history of head injury/NI. Intracranial bleeding. Previous history of previous GIT obstruction or surgery. GIT obstruction. Other factors such as toxin ingestion/drug use, eating disorder. Pregnancy. Examination. Abdominal examination. Abdominal distension could suggest acute abdomen or bowel obstruction. Ask parent if abdomen changed in appearance. Tenderness. Tinkling, high-pitched or absent of bowel sounds may suggest gastrointestinal obstruction. Examination of testes for torsion, particularly in adolescent boys. Neurological examination. Altered conscious state and/or abnormal neurological examination may suggest intracranial pathology. Bulging fontanelle may be a sign of raised intracranial pressure. Look for effects of vomiting. Hydration, c. Management. Investigations. BSL, ketones. If BSL and LT 4-mol/L or and GT 11-mol/L, most well children with isolated vomiting do not require any other investigations. If you are unsure, consult with a senior clinician. Targeted investigation is directed by likely differential diagnoses. Ketotic. Blank. Can be a consequence of vomiting, more commonly in younger children. Treatment. Treat. Blank. With a bolus of 20 ml/kg sodium chloride 0.9%. If BGL less than 2.6 mol/L, and LT 1.5 mol/L in newborns, treat with 2 ml/kg of glucose 10%. If the child is unable to tolerate oral intake or is unwell, start 4 fluids with glucose at maintenance rate as per. Definitive management of a vomiting child based on cause. Gastroenteritis, use of ondansetron. To assist with maintaining hydration in children and GT 6 months of age. For dosage, please refer to. Can be given with vomiting due to head injury provided other signs such as conscious state are carefully monitored. Cessation of vomiting does not exclude serious causes of vomiting. If ondansetron is ineffective, consult senior advice before prescribing other antiemetics due to side effects. Refer to local surgical team if there is evidence of a surgical cause of vomiting, e.g. bowel obstruction, testicular or ovarian torsion and appendicitis. Consider consultation with local pediatric team when. Advice regarding escalation of care. Patient is acutely unwell and not responding to fluid resuscitation. Severe metabolic derangement. Diagnostic uncertainty. Consider transfer when. Child requiring care beyond comfort level of the local hospital. Consider discharge when. Alert and able to tolerate small amounts of oral intake. Normal vital signs. The cause of vomiting has been identified and adequately managed, or high-risk diagnoses have been considered and there is an adequate follow-up plan in place with clear instructions on when to seek earlier review.